I'm going to do the recording. Hello, everyone. Thanks for joining us to our cancer education series. I'm Dick Deming, Medical Director of MercyOne Cancer Center in Des Moines and founder of Above and Beyond Cancer. This program comes to you as a collaboration of Above and Beyond Cancer and MercyOne Cancer Center, and it is funded in part by a grant from the Iowa Cancer Consortium. And it's our treat tonight to have with us Dr. Hayden Warner, and I get to introduce Hayden. We've had a chance to chat. So Hayden is in the middle of his residency in urology at the University of Iowa. Hayden grew up in Illinois, and he went to Eastern Illinois University, where he majored in biology, went to medical school at Southern Illinois University, has a medical degree, and as I said, is now in the middle, he just started the fourth of 6 years of a urology residency. Hayden and I actually connected not through urology, but through bicycling. Hayden is a really avid cyclist and competes at a very high level and is part of the Above and Beyond Cancer professional cycling team. He's going to talk a little bit more about that. And we invited Hayden to come on today to talk about bicycling and as a means of deriving fitness. As all of you who have participated in these seminars know, physical activity is hugely important. Over half of all cancers in the United States is caused by that triad of obesity, inactivity, and just too many calories. And bicycling is one of the great things that we love to do and encourage people to do to help become more fit and actually reduce the chance of getting cancer. So we've asked Hayden, who is not only a doctor who deals with cancer, but an avid cyclist, to give us a little bit of talk about cycling. And he's going to give a talk, and then he and I are going to get to have a conversation about training to be a cancer doctor, about biking, and about urologic cancers. So with that, Hayden, thanks for being part of this, and I'm going to turn it over to you for your presentation.
Awesome. Thank you, Dr. Deming. I really appreciate the opportunity to be on here and give this presentation and chat with you. The presentation is pretty casual, but I'm really looking forward to our conversation after this. I also apologize if my pager goes off and I get a little distracted.
You are excused to do that. If you have to take a call, you just put us on pause.
Well, I appreciate that. Can you see my screen okay?
Yes, we can.
Excellent. So as Dr. Deming said, my name is Hayden. I am a fourth-year resident here at the University of Iowa, and I also started racing with the Above and Beyond Cancer cycling team here over this past year. So it's been a good time, and we can talk a little bit about it. So that's my background. If you would have asked me in high school what I would be doing right now, I may have answered living in a van down by the river. It's hard to say, but certainly never envisioned myself being, a resident here and having gone through medical school. So a little bit about how I came into medicine, and cycling is, all kind of a jumbled mess. I was racing motocross in high school and had an injury my senior year. And this kind of shifted the focus from not being able to race at motorcycles at a high level anymore, transitioning to road cycling. A lot of, motocross is a very physically demanding sport, and a lot of racers have road bikes and mountain bikes to train. So I just happened to have a road bike, and we started doing some of the local group rides and meeting local cyclists. And it kind of, blossomed from there. Started racing in 2010, met a lot of good people, and, that kind of transitions into meeting some of the local physicians who I'd never really had a chance to speak with or see what they do before. So after high school, I went to community college for a year, and was looking at doing personal training or something of that nature. I knew that I love fitness, I love exercising, and I also enjoy helping people and hanging out with people, which is why I do what I do now. But at that time, didn't really realize that was ever a possibility that somebody from my background could actually do. But with these mentors, Dr. John Kay, he's an ophthalmologist back in Effingham, Illinois, which is near where I grew up. He really took me in and kind of showed me, what his practice looked like, how it worked, taught me a little bit about ophthalmology that I hope he's not listening to this, most of which I don't remember anymore. Sorry, Dr. K. But that kind of blossomed this career path and where we're at now. I quit racing bikes while I was in medical school, with studies and everything. It's fairly time consuming, as most people probably know. But then started racing again back towards the end of our 4th year of medical school, and have continued to use that as a way to get exercise, get out some day-to-day frustrations, and kind of it's your competitive edge too during residency. So it's been a lot of fun. So I initially got involved with Above and Beyond Cancer at a race in Utah back in October of 2020. Our 3rd year of research year, we have a 6-year program here instead of the traditional urology 5-year program, which acts as a research year. So we're not in clinics in the OR all day, every day. We have a little bit more flexible time to train. So I was able to travel out to this race in Utah with, I think, 800 or so people signed up. And it was a great time. Obviously, the desert in October was a pretty, you can't complain about that. But there I met Adam Ventling, and we were kind of in the same group in the top, 30 or so riders. We got to talking a little bit, and I, messaged him on Facebook after, just kind of took the opportunity to say, hi, it was great meeting you. And I saw that the team is planning on doing this virtual racing series in over the winter. As you can imagine, with COVID, lots of in-person racing got canceled, which brought virtual racing, or essentially racing on stationary bikes in your own living room. That kind of took the forefront of the racing focus for a lot of people over the COVID time. So just kind of talked to Adam. He was nice enough to not ignore my message and listen to me, and reached out to Randy Reichert, who is the president of the Above and Beyond Cancer team. And we just kind of went from there. It was a great fit. Randy's been putting together a really great group of cyclists from all over the world this year. We have a few guys from Vancouver, one from Slovakia, a couple of Norwegians, and we have a couple guys here, a handful here in Iowa, a few in Colorado. And Randy's done a really amazing job putting together a really unique group of people, and we all get along really well. And I think the focus was certainly the meld of people, and what is everybody doing, what is everybody about, and not just necessarily looking at everybody's race results. So I'm really excited to see what happens in the future with the team, but I guess I'm kind of getting ahead of myself a little bit here. So this is a little bit about indoor racing. If you can imagine sitting on a trainer staring at a wall in pain is fun to do over the winter. I guess we think pretty similarly, or you might be crazy like me, I don't know. But you can see our indoor setup down here. It's just a road bike on a stationary trainer with a power meter that's connected to this app called RGT, or Road Grand Tours is what it used to be called. It calculates how the power you're putting out from pedaling, and as it does with all your other competitors, and you race on this virtual platform. It's, everybody's in a pack. There are drafting dynamics. There are pack dynamics, and it's a lot more fluid and exciting than you might think it was, or than riding by yourself staring at a wall. So makes it exciting, I guess. They even did virtual podium interviews, which was pretty fun for the few times that I got to be on the virtual podium. So they took kind of what they were working with, and they made it a really cool thing. And I think it was a great thing for the team to bond and, get together every other 3-day weekend on Discord and kind of talk with each other and joke and get to know each other a little bit. So all good things happening from the indoor racing scene. Thankfully, this winter, spring, things started to let up a little bit as people got their vaccinations and infection rates dropped. So we actually, a few of us took a kind of a little mini camp to Tucson in February, which was a lot of fun. And most of these pictures are from our Boulder team camp in May. You can see there pretty much most of the team was able to make it, except for, a couple of people who were back home, mainly the Norwegians who, weren't able to get back yet. But a great time in Colorado. Again, you can tell, I think we make it pretty obvious that we have a good time and we all get along together. But it's a really incredible group of people that Randy's worked on putting together. And again, really excited to see what we can do and see where the team goes over the next couple of seasons. In addition to team camp, thank goodness we finally got to do some in-person racing too. So this top picture is from the Tour of America's Dairyland, which is a 9 or 10 day criterium race series. Criteriums are typically shorter circuit type races in town that were, anywhere between 60 and 90 minutes. So short, but fast and hard. And I was able to do a few of those races. I had to get back for some work related stuff. I was able to do a number of another race series, the Intelligentsia Cup, which was another 9-day race series in Chicago a month later, about 4 weeks ago. So, we got to spend the week together in an Airbnb, hanging out, having a good time, learning, getting to know each other. I think it's really unique how all of us have different racing backgrounds and just life backgrounds in general. So whether it's, on a personal level or racing, we all learn from everybody else. So pretty good stuff. But yeah, it's been really nice to race in person with all the people that we've been on Discord with the headphones on racing with over the winter. So it's been pretty fun. This is Timmy. Timmy Bauer is one of the best human beings that I know. He's on the team. He lives out in California. Was kind of originally known for indoor racing with one of the bigger indoor racing teams a couple seasons ago. And I was he knows this already, but I was a little bit of a fanboy when Randy asked me to text him one morning and add him to the group chat. So Timmy's one of my favorite people, but he's such a good guy and always so positive about everything. But these are some of the team goals coming up for the rest of the year. Joe Martin Stage Race is a big race in August. It's 220-mile road races followed by an uphill time trial the next day, and then a shorter 60-minute circuit race on Sunday. The Tour of the Gila is down in New Mexico, which a number of us, I think we have a full team going down there. It's at altitude, lots of climbing, so it should be pretty hard for the guys. I can't say that I'm upset that I'll be stuck here working for that one, because I think work sounds a little less painful than that. So my schedule will be just a little bit more limited. I'll be doing hopefully most of the race series in St. Louis here over Labor Day, and then a Belgian waffle ride, which is actually a race in October. So it's a 105-mile gravel ride, which will be fun. It'll be I think a couple of the other team guys are doing it. I think Adam Ventling said he's going to do it. So I'll have some team guys out there, and hopefully we can kind of see how we stack up against some of the other best gravel guys in the U.S. So this is a picture of, this is me in the middle. This is Brendan Hardy on picture right. And this is Brian. So he was one of my co-residents up to very recently. He took his own life in early July. And, I just kind of wanted to include this because the road to becoming a physician is really difficult. And I just wanted to kind of tie this all into, Above and Beyond's mission is to elevate the lives of those touched by cancer to create a healthier world. This isn't, in my mind, I kind of was thinking about this a little bit more since all of this happened. And, it's not necessarily just patients and patients' families. It's the physicians. We're right there with all of our patients when they get diagnosed with cancer. We're the ones that, have to spill the beans and tell them, this is what you've got going on. We have to explain to the family. So I wanted to kind of, not for selfish reasons, but I just wanted to include this in there. It seems like sometimes the physicians are held, on on a different level to the patients. And, we're all kind of in this world just trying to make it together. So that's, I think, why I'm so happy to be in the career that I'm in, is we get to help patients with, in urology, their kidney cancer, bladder cancer, prostate cancer, and a number of other like kidney stones and other things that, really distress people. But I just wanted to kind of tie in that we're right there with everybody. And, we feel the pain too. And, it's emotionally hard on us too. So, but we all do it because we love helping patients, and we just want to be the person that can help them out of that hard time. On to something a little bit lighter, I guess. I threw in a few slides here talking about cycling and our health. We could probably talk all day about, certain aspects of cycling, the cardiovascular benefits for certain health conditions and that sort of thing. But I really wanted to kind of focus on, what my specialty is, urology. So kind of keeping it a little bit brief on the overview part. Aerobic activity, great for the cardiovascular system, as Dr. Deming said earlier. Aerobic activity, amongst a number of other things, promote health, decrease obesity rates, can improve your risk of cancer, which is all great things. I wanted to emphasize a little bit that cycling is kind of it's great for aerobic, but it's not a bone building sport. So it's certainly necessary to do other cross training type things like walking, weightlifting. I suppose hiking up mountains is probably is one of the hardest things to do. So certainly included in this, but you don't want to ignore one big part of your health to just focus on something else. Certainly cycling is great and it's super fun, but doing some of these other impact activities is great for your overall health as well. So some of the main concerns that you hear talking to cyclists is mainly on our end, erectile dysfunction and saddle numbness and genital numbness, which isn't uncommon amongst bike riders. You can see in the picture here, right where you're sitting, this pudendal nerve is going through that provides the sensory function to all the parts in concern. So Dr. Breyer is one of the guys out of UCSF. I stole some of these slides from him. I hope he doesn't get too mad. But he gave our grand rounds actually the other week on urologic trauma and cycling and some of the studies that he's done. He's been one of the big researchers in cycling and urologic research over the past 5 to 7 years. So I wanted to pull out a few of his things. I included some graphs for those who want to kind of look through them a little bit more. But this graph here on the left, the SHIM score is a measure of erectile dysfunction, and the IPSS score is a measure of lower urinary tract dysfunction. So burning with urination, other problems urinating, like urinary hesitancy, where it takes a while to start, or you kind of start-stop. Intermittency is what we call that. But on the right, you can see on the x-axis here, lifetime miles. They kind of divide it up, and more lifetime miles shows a little bit higher rate of no erectile dysfunction here in blue compared to 0 and 1. And then over here up top, where the erectile dysfunction gets a little bit worse, there's less green here in this graph than there is here, and proportionally less of these as well. Which, the main point of this graph is to show that more lifetime riding doesn't necessarily lead to erectile dysfunction. And this says the opposite, is that, improving your aerobic fitness should improve your sexual function. And similar thing over here with the lower urinary tract symptoms, pretty similar rates across, nothing too discernible here. So, and we'll kind of talk about that a little bit later in the talk, but I wanted to kind of focus here on the erectile and the sexual dysfunction. So this graph is from one of his papers, multivariate regression, looking at a number of other factors that they took in, showed that the sexual dysfunction count here, this survey that people can fill out, showed relatively, I know these are significant values, but relatively the same values, compared to non-cyclists. This was a study done with other not necessarily elite athletes, but swimmers, runners, essentially aerobic athletes who are not cyclists. And the main point that I wanted to kind of pull from this is, these are fairly similar numbers here, 19.5, 19.9, 20.7. And you can compare this to the genital numbness down here, obviously reference range of 1 for people who don't ride bikes, and higher rates for people who did ride bikes, with cyclists riding more having a higher rate of genital numbness. And that's not necessarily correlated with this sexual function score. So I just wanted to kind of bring that to people's attention. The numbness that is fairly common for the new cyclists and experienced cyclists, all comers, doesn't necessarily lead to sexual dysfunction, as some think it might. Not surprisingly, if you look at saddle sores, you ride more, you get lots more saddle sores than if you don't ride. So great research coming out from Dr. Breyer, though. Some other things I wanted to point out from his study: standing greater than 20% of the time, significantly improved. I forgot to change that from increased to improved genital numbness. I'm not sure if I can do 20% of my rides standing up, but certainly intermittently standing up and sitting down is one of the ways that I try to combat any sort of numbness. Less drop between the seat and the handlebars reduce saddle sores and numbness. So if you can imagine your seats here and your handlebars are way down here, you're leaned much further forward and you have so much more pressure on this pudendal nerve here. So that can certainly lead to numbness. So having a more equivalent handlebar saddle height seemed to cause less numbness and saddle sores. And kind of a different study, but similar work here, looking at sexual dysfunction and perineal numbness. Again, I highlighted the important points that I kind of wanted to bring to light in this talk, that sexual dysfunction was, sexual function was better than the reference range in the non-cyclist, and as perineal numbness went up, wasn't necessarily correlated with an increased risk of sexual dysfunction. So one of the other things, I don't think it's talked about a whole lot. Dr. Amy Perlman is one of our staff here who I think does a really good job, kind of tying pelvic floor dysfunction into male lower urinary tract symptoms. It's one of those things, it's hard to diagnose because you can't point to something and say, that's, as a surgeon, I can't surgically fix this, or this is the problem. So, but pelvic floor dysfunction, as you can see up here in this picture, it's essentially a fruit bowl of muscles that hold your bladder and your pelvic organs up. You can see here your urethra goes through that musculature. And if that musculature is overly tight or doesn't relax like it should, it can certainly lead to lower urinary tract symptoms like discomfort with urination, trouble starting your stream, trouble, like we said, with intermittency, where you start and stop your stream as you go. A weak stream, if you can imagine a muscle that's not entirely relaxed against the urethra, it kind of narrows the plumbing down a little bit. And even problems completely emptying your bladder, where you have a little bit left in there. And, if you don't empty the tank all the way, you fill up quicker. And, people, report urinary frequency going too often with that. So I certainly think it's something that should be kept in mind in everybody, but especially in athletes of high intensity sports, especially cycling with a lot of pressure down in the perineal region. Some of the at-home ways that you can combat this is reducing stress. Easy to say, right? Relaxation, meditation, yoga, those sort of things have been shown to help. But if you're really having problems with this and you're just not quite urinating like you used to, a urologist can refer you to a pelvic floor physical therapist. Now, not all physical therapists are trained in these kind of specialty things, but they can certainly show you exercises to help relax, stretches, and that sort of thing. That can really help a lot of folks out with what can be pretty bothersome. So this is I love getting this question. I feel like anytime, especially here at the VA, for any of our vets who just got bikes or who are out doing stuff. You say you ride bikes and they say, oh, I ride a bike too. It hurts. What do I do? I'm certainly not an expert in bike fitting, but I think, bike fit is key. Your local bike shop can certainly help you get everything kind of squared away if you're not comfortable and you don't really know where to start. Obviously, so this is a picture from Maurice Hessel's laboratory. We'll call it a laboratory from In Motion Bike Fit in St. Louis. Obviously, not everybody needs these sensors connected to measure their ankle angles, their hip angles, etc. But it does show you the importance of fit in not only performance, but health and overall well-being. So I usually start with people asking them about their seat height. I think, a lot of people ride their seat either too low or sometimes too high too. If you can believe it, it's easy to imagine if the seat's too high, you have too much pressure on the perineal region and it can cause you some pain and discomfort in the perineal region on the butt. But, actually having it too low as well, takes some of the leg muscle and leg support out of it. So you can have a little more pressure on your sit bone area. So a good rule of thumb is about 25 to 30 degrees is what I learned in knee bend with your pedal straight down. So with your pedal as far away from the seat as it gets, you want to have about 25 to 30 degree angle. So you're not overextending, but your knees aren't all crunched up either. Another thing that you can do is stand intermittently, like Dr. Breyer's research says. I try to do it every 5 or 10 minutes. I stand up for 5 or 10 pedal strokes. So it's easy enough to kind of remember that way, just doing it every once in a while. Another thing that I think people do is they pedal on, when they have flat pedals that come on standard bikes, they tend to pedal on the heel of their foot, which kind of throws the knee and the hip angles off where they should be for optimal power transfer, but also comfort. I think moving the foot a little bit further back on the pedal to where the ball of the foot is around the pedal spindle, that little spin, the little axle that the pedal spins around. That allows you to put a little bit more, get a little more leverage out of it. And it's a little bit easier in your knees and hips as well, because you can use that as a third joint essentially, because it is one. Unfortunately, I don't think getting a bigger, cushier gel seat is going to help your butt problems. I think there are a lot of other things that we can do though before we go down that route to get us where we need to go. And if your hands and wrists are hurting, try raising the bars a little bit if you can. Or if you have a little bit of room to come down in your seat too, you could try that. If you imagine you're leaning way forward and you have a lot of pressure on your hands, that can cause some hand pain no matter how short or long your ride is going to be. And I think the neck pain, the neck discomfort is another one that, is a little bit tough to address, because anybody who gets a road bike, they have their bars, even if they're not super low, you go down, you're hunched over and you tilt your head up like that, which really kind of kinks your neck back. But it's not necessarily that your neck's kinked back is where the pain's coming from. I think a lot of that tension is transferred through the shoulders, your triceps and everything in a really tight upper body. So if you can kind of work on relaxing your shoulders, your traps and your arms, using your core to engage to kind of keep you upright rather than leaning on your hands and cramming your neck up, over time, I would suspect that your neck will probably start feeling a little bit better. But certainly raising the bars a little bit isn't an unreasonable place to start as well. So cycling's supposed to be fun, so relax and just enjoy the ride. So that's my presentation. Anybody who has questions or just wants to chat, this is my Instagram handle. That's my email if anybody needs my email address. And I put this looking forward to RAGBRAI in there because July is when our interns start. So we're not, even though a lot of our staff are on vacation in July, we're technically not supposed to take vacation or leave in July. So I'm very much looking forward to the first July that I won't absolutely be working all the time in 2024. So hopefully then I can do the whole week of RAGBRAI, which is going to be awesome. And hopefully we see some of you guys out there.
Great. Hey, thanks, Hayden. Let's have you close down your PowerPoint, and that'll make you and me bigger as we begin our conversation here. Hey, that was great. Thank you. First of all, though, let me just offer you your sympathy and condolences for the loss of your colleague, and thank you for sharing that, bit of humanity. It's good to remind everyone that a doctor caring for a patient is a human being caring for another human being, and that we all experience the joys and sorrows, and that I'm sure you've learned already, and you will learn even more and more, that as you have the opportunity to share the highs and lows of cancer journeyship with your patients, they will be comforting you just as you are comforting them. I remember one patient so clearly as I was telling her that her cancer had come back and become incurable, and her first response was, "Oh, doctor, that must be so hard for you to have to tell me that." And you'll just be amazed at the comfort that you will get as a physician from your patients by being a human being caring for another human. So thank you for sharing that. And you're absolutely right. Above and Beyond Cancer is all about empowering everyone who's touched by cancer, and that includes the physicians as well. Let's see first of all, if we have any bicycle related questions we have a live studio audience, and we also have a group that are going to ask their questions via chat. And then, so let's see about chat. So we'll turn to our live studio audience here. Questions about bicycling for Hayden. So Hayden, here's one while we're getting to other questions. Tell us about your very first bicycle.
Yeah, so my first bike that I can remember, I remember lots of skinned up knees. I think my first bike that wasn't with training wheels was a silver Huffy, which may or may not still be in my parents' garage, all rusted out and broken. I'm not entirely sure, but it was pretty sweet, and it went through some stuff.
Good. Well, I hope it's still there. We have a question here. Tim, you have a question?
Well, we have a spinning class in about half an hour, and you opened up my eyes to the different things that might happen to your rear, right? So if you're spinning, like spinning classes and things like that, is that a lot less stress on your lower area than just regular hardcore biking that you do?
Sure. Yeah, that's a great question. So I have done a few spin classes, and kudos to you for doing them, because I think it may have been the mindset that I went in with, but those were harder than I think any race I've ever done. But certainly, so my one concern or thought on the spin bikes is because that they have a fixed flywheel. It's essentially a fixed gear bike, and the flywheel is quite heavy compared to what your normal rolling resistance might be. I find myself, and it sounds like a lot of other people, spinning very quick, which, if you can imagine spinning your legs quicker with less tension versus a slower pedal stroke, you tend to take more force off of the perineum when you have a slightly slower cadence or pedal stroke than you do with a faster one. So I find myself, anytime I'm in a lighter gear that would kind of simulate a spin bike, or on a spin bike, that I have to consciously put a little bit more tension on than I might normally, slow the legs down a little bit, or if your legs are able to keep up with it, you can stand up as you're pedaling a little more frequently. But that's certainly where I find myself usually.
Great. And you talked a little bit about getting a bigger, fatter, softer gel saddle is usually not the solution to the pain that you have in your saddle. Maybe talk about, obviously, the more you ride, the less the easier it gets and the less discomfort. Maybe talk a little bit about bike shorts and what to wear, especially, we have a lot of beginners that come to our spin class who might have been out, lifting weights or walking around the track. And how does what you wear when you get on a spin bike affect your comfort level?
Yeah, so certainly, especially with the indoor stuff, I've become semi-accustomed to that with the indoor racing, I guess. It's certainly a little more uncomfortable than outside, because you're dealing with the cooling issues. You're dealing with more sweat that's not just evaporating with the wind in your face. So I think the first thing that, people kind of go to and buy are padded cycling shorts. So these are spandex or tighter shorts that have a chamois or a pad in the butt region, essentially, where you're sitting. And it does a great job of taking some of the friction off, but also taking some of the pressure off of your sit bones there, which I know, people have problems with both. In addition to that, there's chamois cream. So there's an antibacterial or a kind of a lubricating cream that takes some more of the friction away, and it has a nice cooling menthol effect too, which is kind of nice sometimes. If you're in bike shorts and you're still having some saddle discomfort, but I think bike shorts are a really good first place to start. Now, for the person who's coming in off the walking track saying, hey, I want to do this will be fun, basketball shorts or athletic shorts are so uncomfortable on the bike. I rode to the hospital in jeans the other day, and it was so much more comfortable on the saddle than like athletic shorts were. So it's kind of it's a tough mix, I would say try to at least wear, more supportive underwear if you're gonna wear athletic shorts for the first few times. Bike shorts are a must though for those. And then, keeping cool up top, a lighter layer up top that's going to absorb sweat and help keep you cool and kind of wick the moisture away, I think is really key, and having a towel to towel off and cool off.
Other questions from our folks here? Well, while we're waiting for other questions, one of the things that you touched on, and I think it's important, is, there is no one sport that covers every aspect of fitness. And as you pointed out, you can get great aerobic fitness with cycling, but it doesn't have a lot of resistance to it. And especially as we get older, whether you're a man or a woman, muscle and bone strength becomes an important issue. And are there some, for example, standing while you're cycling, does that provide a little bit more? Does the type of bike you're riding, if you're hammering over a rough terrain, you're going to get a little bit of impact. But basically, you're saying that, it's great for muscle development, it's great for aerobic, but not the best exercise for building strength in your bones.
Yeah, and I think, there are a lot of schools of thought on, for example, the musculature. So a lot of people will do, if they want to strength train, they'll just throw it in a super hard gear and turn their cranks as hard as they can, just really slow. But if you compare that to even a body weight squat, that's not that much force. So, really developing that overall athlete strength, that bone strength that's going to be key in years going forward. I think there are certainly better exercises that you need to incorporate in. I've been cycling pretty specifically for a while without doing much else. And now it's gotten to that point where you have these kind of aches and pains, and you're like, okay, well, I should probably do a little bit of cross training and, build myself up a little more as a person and not just a bike rider. So focusing on your bone health, your joint health, and all those other aspects other than just your aerobic system.
Great. Any other questions about biking? Okay, Teresa, I'll repeat it.
Okay. Just in biking as entry level, and as you increased your time on the bike, and then you became faster, was there any time that you experienced fear, maybe in a decline or in a race where there's multiple people around you?
And you're smiling. I assume you heard the question okay, Hayden?
I did.
Okay.
That's a great question. I think the answer is yes. Everyone is scared a lot of the times. Anything that you're doing on a bike is going outside of your comfort zone and kind of pushing the boundaries of your comfort zone. I think once you do it a couple times, you get a little better at it. Like that, for instance, that little gravel patch that you've always been scared of, and then one day after you've like hit it 5 times and not crashed, well, I'm not so scared of that anymore. But the dog that's chasing me now is scary. But my background is in motocross, so pretty much all things cycling related seem, don't get me wrong, the criterium racing and road racing is still pretty, we'll call it argy-bargy, where you're elbowing people and you're shouldering people out of your way, trying to get the position. But it's all about kind of where you've been and what you've pushed your comfort level to be. And I think, everyone starts from a baseline and just keeps pushing the boundaries. So keep it up, I guess, is the answer to that question.
Yeah. Your comfort zone expands with experience.
Absolutely.
Yeah. I'm going to switch gears a little bit here. We still have about 20 minutes, and I want to talk to you about becoming a doctor. So thanks for sharing a little bit about your life story. And obviously, before you get to your residency, you've gone through medical school. But for most people in the audience, you should know that during medical school, you're very seldom in charge of any patients, and you're obviously learning, so you don't get the opportunity to really be the person in charge of a patient, and it's not very common that you have the opportunity to learn a lot about telling patients that they have cancer and guiding them seriously on their journey by the time you rotate every month from one service to another service. So I want to talk a little bit with you about your experience as a urologist. You're often the first doctor that might be telling a person that they have kidney cancer or bladder cancer or prostate cancer. And maybe reflect a little bit on what that's been like. It's one thing to learn about the physiology and anatomy of the urinary system and learning how to make incisions and operate all the various robotic equipments and needles and scalpels, but it's a different experience to sit in a room face to face with someone and tell them that they have cancer. So maybe reflect a little bit on that experience as you go through training, what you might do differently now as a 4th year resident than you did as a 1st year, and what you've learned over the 4 years during your training so far.
Yeah, no, absolutely. Urology is interesting in that, the cancers that we generally deal with, the most common being kidney, bladder, and prostate, they're all generally very different courses, as you know. The bladder cancer can be a pretty scary beast, especially when it's aggressive enough that it's invading through the bladder muscle. So that's, a very different conversation that you have with somebody who, they got a CT because they fell out of a tree and they had a little blood in their urine. So they got a CT of their abdomen pelvis, and it showed this, 3-centimeter kidney mass there. So we have the opportunity to have a lot of different types of discussions. It's hard, as you know, with training, you're thrown into the deep end of the pool. Sometimes there's no water in the pool and you just hit the floor of the pool is what it feels like. But it's certainly, so the first few years of training, you're trying to learn all this stuff. You're trying to learn the guidelines. You're, learning, okay, this person has this, the algorithm to do now is this. I'm going to, tell them that they need surgery, or I'm going to tell them that we're going to keep monitoring them with imaging and periodic testing. But, you get to our 2nd year is one of our endoscopic heavy years, where we do a lot of bladder tumor resections through the urethra and the bladder. And we do a lot of the managing of non-invasive bladder cancer. So you really, I think that's probably one of our first opportunities to get to know people, because I mean, you see, you're essentially the same service for the whole 12 months. So you're seeing them potentially from their first bladder tumor resection, and then for their first restaging cystoscopy and bladder biopsy after their bladder chemotherapy. And then, okay, well, it's negative, positive, where do we go from here? Kind of talking to them on the phone through that and giving them the results. And, you looking back on it, you have to give people a lot of bad news over the phone, which is, just kind of how our clinic is, set up. They're coming in every week sometimes for these bladder chemotherapies. So to prevent them from having to drive another 3 hours from, central Iowa over here, just to have that conversation, most people are okay talking about it over the phone, but it's hard to get that. It's hard and it's not hard to get that, that human interaction there, but you really get to know these people really well. So there was one gentleman that I treated, I did the majority of his procedures. He'd already been, down the line a bit and had already had, a kidney and ureter removed. He'd already had some other procedures done, and he was, down the line in his non-invasive bladder cancer treatment. And, he just turns into family. You call him, you don't even have to introduce yourself. You just start talking about, what their grandson's been doing and this other stuff. So yeah, it's certainly, as you go, you kind of transition, like you said, from medical student to, more junior intern and more junior resident, where you're learning the algorithms and what to do and why to do it. And then once at least for me, once I've finally got to a point where I could kind of put those on autopilot and had those in my brain enough, you could finally, I don't know, let yourself become a little more vulnerable and actually take the time to feel what was happening, and not just, okay, this kidney mass, this treatment, we'll see you in 6 months for your scan. You really, once you get to take that time and, really get to know the person and, feel with them, it's pretty incredible.
Yeah. So you talked about the way that urology works. It's often the follow-up happens by phone. And so let's give an example. So prostate cancer. Obviously, nobody gets told they have prostate cancer without seeing a urologist and having a biopsy. I mean, we're talking about a primary prostate cancer. So what's the flow of, so a patient has an elevated PSA blood test that their primary care doctor had done and said, I'm going to send you to a urologist. And so they come to see you, and let's say you talk with them about doing a biopsy, and you proceed and do the biopsy. What would be the normal path by which you got the results and you informed the person that you did the biopsy on that they have cancer?
So it depends a little bit on what staff is overseeing you. Some staff have that conversation on the phone by themselves. I think it's a little more rare to bring them back to clinic unless they have a pretty good suspicion that it's going to be, a tougher conversation and maybe worse cancer. Sometimes they'll bring them back to clinic to have that conversation. But a lot of times for the biopsies, the path result comes to, your inbox. So, and I don't know if I think you guys are using Epic over there.
We have a different system, but it works the same way.
Perfect. So you get a message in your inbox, you look through it, I look to see if anybody else has talked to them about it. And, I just kind of give them a call about it. I would, wouldn't want necessarily somebody teeter-tottering around, do I have cancer? Do I not have cancer? I had this biopsy a week ago. Why hasn't anybody called me yet? I don't have any appointments scheduled. So you try to get it taken care of and call them as soon as you can. And, you, from meeting the patient, you kind of have an idea of where their understanding of what may or may not be going on, which is a nice reference point, because with some folks, you have to start, at the very basics, like kind of reminding them, this is why we did the biopsy. These were the results of the biopsy, as we talked about kind of before the biopsy, these might be our treatment options if this is the case, and kind of going into those a little bit more. You try not to get, on the phone, once somebody hears like, oh, I have, even if it's grade group 1 prostate cancer, which is, for anybody, introductory level prostate cancer, it's the lowest grade that's called prostate cancer. Even after most people hear that, I would say 90% of people probably just, that's all they hear about the conversation, and that's it. So certainly making sure they have clinic follow-up and kind of discussing what we need to do next, whether that's, come back with one of the other the staff who did the biopsy, and talk about if they're, a robotic prostatectomy candidate to take the prostate out, making sure they have appropriate clinic follow-up, and, have that kind of document the conversation that you had. So one of your co-residents who's probably in a similar position as you, if it's not you, can sort of carry it forward, and they know roughly where you left off.
Yeah, so I'm a little more interested in that conversation you have with the patient as you're telling them they have cancer, and these would be patients typically you've met in person before you are calling them.
Yeah, generally.
Yeah.
It's a tough conversation. Usually I'll kind of ask, I already have an idea, but I don't like to ask questions that I don't maybe already know the answer to either. So asking them what their understanding about their disease is, and, trying to get an idea of how much they want to know about, what their prognosis is, what the disease is, what causes it, and, other associated, is my family going to be impacted by this? Is my family at risk? Is a common question that people have. And kind of being ready for them. I like to start the conversation, get a feel for where they're at, and then kind of let them go where they want to go, and kind of piggyback off that. Because it doesn't do any good if I just start talking about, your pathology report says this is this, the treatment options are this. What do you think? That does no good.
Yeah, listening is an important part. So Hayden, have you had the opportunity to be involved with the ongoing care of patients with incurable stage 4 cancer?
Yeah, so that's, being a tertiary medical center, that's certainly one of the patient populations that we deal with. Bladder cancer is we're a big bladder cancer center here in the Midwest. And even after you put some patients through a big surgery, a bladder removal, and they come back with some variant histology that's very aggressive historically. And then, we've had a few patients who their disease progressed so rapidly that they had their surgery and never made it out of the hospital, not because of post-operative cares, but disease progression in that fast time. And that's certainly, watching somebody from their surgery where they were relatively healthy appearing to, 20 or 30 days later, just a shell of what they were before, and their family's there the whole time. And you can see, all the transitions and all the, every emotional state you can imagine from family members and the patients. It's hard. And you have to have a lot of sit down after 6 p.m. when you're still just hanging out around the hospital and just talk and see how they're doing.
And what have you learned about yourself in this journey, and how has caring for cancer patients maybe changed your philosophy, your thoughts about meaning, purpose in life, just the way you live your life?
Wait until the last few minutes to throw hardballs. No, it's really, everybody when they're applying to medical school gives the same spiel of, yeah, I want to help people, let me in. And then you apply to residency, it's like, yeah, I want to help people, I want to do this specialty, like, let me in. But as you get into that, there's fewer and fewer end games, I guess. Like you always have that finish line, and there are fewer finish lines. It's just, you continue practice after this on your own, doing the same stuff. And really getting in, it's really nice being here at the VA, because we are essentially the urology service. So we are, taking care of patients from beginning to end of their care, and you really get to know them really well. And, having those tough conversations, having the successes, the cases where you resect a bladder tumor, and it's great. The highs and lows, there are lots of both. And just kind of, I don't know, embracing both of those. And I think, especially with some of the stuff that's happened over the past month, it's definitely made you realize that life's pretty brittle, and everybody's human, and everybody puts 2 legs in pants every morning and just goes and lives their life how they do. So it's very humanizing, I think, what we do, if nothing else.
Yep. We're all just dangling by a thread. And one of the most gratifying things for me about being a doc is those human to human relationships. To think the position you're put in, this sacred space of talking with patients about their joys and sorrows and their fears, and being able to share times of joy and also times of sorrow with patients and with their families. It's just a sacred space to be in, and understanding it's that emotional intensity as of the highs and the lows. It really creates the meaningful impact of life.
Yeah, for sure.
Other questions for Dr. Warner from our group here? So I think we're coming to the end of our time, Hayden. And number one, I just want to tell you how much I admire you for what you're doing to be engaged in this very difficult, time-consuming residency and still take the time to, pay attention to yourself, to your own health, and to be helping to get out there and racing. And for those who maybe don't understand, the Above and Beyond racing team is also about developing younger riders. And I'm sure you're a fabulous mentor to those younger folks on the team. And so thank you for being part of the Above and Beyond Cancer Racing team. Thank you for taking time from your busy schedule to speak to our group today. And I look forward to collaborating with you on all sorts of great things.
Same to you, Dr. Deming. I just can't believe my pager didn't go off during this whole thing. It's a miracle.
Better make sure it's not on silent.
That's actually a good point. I probably should.
So, well, thanks again. I'm just going to close this out by thanking everybody for attending. For those of you who want to watch this again, this video podcast will be available online at Mercy Cancer Center website, and it will also be available at the Above and Beyond Cancer YouTube channel. So please join us next week. Thanks for being with us. And Hayden, we're headed to the spin room to do a little spinning now.
Don't forget your bike shorts.
I will change into bike shorts, and I also never forget my Tina Turner soundtrack.
There you go. Perfect.
Okay. Thanks a lot. Thanks, everybody. Bye-bye.
Thanks a lot.